Hello, this PowerPoint presentation will be on pharmacodynamics. What is pharmacodynamics? Pharmacodynamics is a study of the biochemical and physiologic effects of drugs and the molecular mechanisms by which effects are produced. The study of what drugs do to the body and how they do it. So this is a study of what the drugs do to the body. Pharmacokinetics is what the body does to the drug. Okay, so remember that concept. Pharmacodynamics includes the dose-response relationship, the drug-receptor interactions, drug responses that do not involve receptors, interpatient variability in drug responses, and the therapeutic index. Drug response relationships. This is a relationship between the size of an administered dose and the intensity of the response produced. It is determined by the minimum amount of drug to be used, the maximum response the drug can elicit, and how much to increase the doses to produce the desired increase in response. And we know always that we want to, it's a big rule that we want to start low and go slow in many meds so that we don't overwhelm the patient's system with too much medication. In my practice, I find a lot of times patients come to me, they've been started on not the recommended starter dose, but a more normal maintenance dose. So they've had more side effects, which has made them not feel well. While they might be getting some of the effect they need, they don't feel well from the side effect profile. And then their compliance, of course, they don't want to take the med or they're afraid to take the medication. As the dosage increases, the response becomes progressively larger. That is the hope of medications, is that we need to go up as the responses. So for my practice, of course, when I start patients on meds, we start low, go slow. We leave a dose once the patient gets a response that's acceptable. I'll leave the dose there, with the caveat that if their depression or anxiety increases, or they aren't really happy with the results they've gotten, that we can go up on the dose, and not just to keep going up on the dose for the sake of going up on the dose. So therefore, treatment is tailored by increasing or decreasing the dosage until the desired intensity of response is achieved. And for my patients, of course, it's what they tell me how they feel and when their symptoms are improved. You may be doing that based on lab results. You may be doing that based on blood levels. So it all depends on how you're going to do that. Many times, for instance, when you start a patient on treatment for hypothyroidism, you're going to base it on their weight, and so the dose is going to be high. Then once you start checking their TSH levels, you may have to decrease that dose, because now that the body has received as much of the thyroxine as they need, you can back off on actually how much you need to give them to maintain a appropriate level. Drug receptor interactions. So for the drugs, it's the chemicals that produce effects by interacting with other chemicals. The receptors are special chemicals in the body that most drugs interact with to produce those effects. So what is an effector? A receptor, I'm sorry. A receptor is any functional macromolecule in a cell to which a drug binds to produce its effect. Technically, receptors can include enzymes, ribosomes, and tubulin. The term receptor is generally reserved to refer to the body's own receptors for hormones, for neurotransmitters, and other regulatory molecules. Receptors and selectivity of drug action. The more selective a drug is, the fewer side effects it will produce. Receptors make selectivity possible, and each type of receptor um, participates in the regulation of just a few processes. There is a lock and key mechanism, does not guarantee safety, and the body has receptors for each of the following neurotransmitters, hormones, and all other molecules in the body used to regulate physiologic processes. This concept is, I talk about it a lot with my patients in psych, um, with the neurotransmitters. I use it to explain initially why it takes so long for the meds to start working. You know, with your antibiotics, they're going in to look for um, the bacteria that they are set up to uh, get rid of. So, but with the neurotransmitters, we're looking at basically serotonin, dopamine, norepinephrine, and maybe GABA. With those neurotransmitters, what happens is with depression, let's say the body isn't making the level of serotonin needed to keep the patient out of depression. Well, when they decide to start medications, the medication doesn't actually give them serotonin. The medication actually helps their brain to produce more serotonin so that they can have the chemical reactions um, to ward off the depression. Well, during that depressed state, they're not making the serotonin. Um, it takes time for the body to then manufacture that new serotonin or norepinephrine or dopamine. So I explain that to the patients. That's one reason it takes longer. And I do explain also there is like a lock and key mechanism, especially with the GABA system, which is the neurotransmitter involved with anxiety, one of the principal ones. There is a real lock and key. So the medications that I prescribe for anxiety, especially the benzodiazepines, really have a lock and key effect. They fit right into, it's like a puzzle piece also fitting in, if you want to think of it that way. And then that chemical reaction does occur. Okay, there are theories of the drug receptor reaction. The single occupancy theory, which states that the intensity of the response of a drug is proportionate to the number of receptors occupied by that drug. So, therefore, the maximal response occurs when all available receptors have been occupied. The problem with this theory is that it does not explain why one drug is more potent than another if they bind with the same receptors. Therefore, we have a modified occupancy theory, which looks at the affinity, so that some drugs have a greater affinity for the receptor sites, therefore, their response will be improved. I've told that a lot with the D2 receptors in my practice. They'll say, well, this drug has a greater affinity for the D2 receptors or D3 receptors, especially the newer medications, when helping with patients with their symptoms of psychosis. So that just means the strength of the attractivity. There's also intrinsic activity, which is the ability of the drug to activate a receptor upon binding. There are drug receptor interactions. You have antagonists, agonist, antagonist, and partial agonists. So, what are agonists? Agonists are molecules that activate the receptors. Their endogenous regulators are considered agonists. Agonists have both affinity and high intrinsic activity, and agonists can make processes go faster or slower. So when you want to give a med to give the effect that you want, you're typically giving an agonist. So an antagonist, they produce their effect by preventing receptor activation by endogenous regulatory molecules and drugs. They have an affinity for the receptor but no intrinsic activity. They have no effect on their own. They do not cause receptor activation but cause um, physiological effects by preventing the activation of receptors by the agonist. And if there's no agonist present, there's no observable effect. An example would be patients that are carrying Lanoxone, Narcan to counteract an overdose from their opiate use. Um, if they have taken too much of the opioid, the naloxone will um, counteract that and occupy those receptor sites and stop the reaction. But in and of itself, it does not cause any kind of chemical reaction to the patient. So what is a partial agonist? Partial agonists have only moderate intrinsic activity. The maximal effect that a partial agonist can produce is less than that of a full agonist, and these can act as an antagonist as well as an agonist. An example of that now would be like Suboxone. Suboxone is a partial agonist um, of for the opiates, so it has a very strong affinity for the receptors, so it can knock out the opiate use, and it does have some effects. So we have to be very careful that the patient isn't using their opioids, because the combination of using their opioids with the Suboxone can put them into an overdose and fatal reaction. What does happen with this is that we do add usually the Suboxone has the buprenorphine with the naloxone, so that you also have that strong antagonist that will also knock the opiate off of the receptor sites. You have regulation of the receptor sensitivity. Receptors are dynamic cell components, of course, and the number of receptors on a cell surface and the sensitivity to agonists can change in response to continuous activation and continuous inhibition. This is another concept that, along with the concepts of continuous exposure to the agonist, which you get a desensitization, which causes a downregulation, or you can have continuous exposure to the antagonist, which causes a hypersensitivity. Um, One of the things that I do talk to patients about is, again, with psych, when I mentioned earlier that it may take 4 to 6 weeks for the meds to work in some cases. One of the reasons with depression, again, is that you've had a decrease in the number of you have a decrease in the number of serotonin neurotransmitters that are produced. Those have to be produced to couple with the receptor sites in order to make the reaction needed to keep the depression down. Well, when a patient's depressed, they're making less serotonin. When they're making less serotonin, eventually you get a downregulation of the receptor sites because they're not being used. Um, so when I tell the patient, it's like when you have boat slips at a lake and nobody's using those anymore, many times they'll take the boat slips down. So when we give the medications that have the brain to um, increase the production again, besides getting that production ramped up, we also have to wait for the brain to upregulate um, receptor sites again to receive the increased amount of serotonin neuro, chemicals that are being produced. So all of that takes time, and that's why it does take several weeks for the meds to be effective for the patient. There are drug responses that do not involve receptors. These are simple physical and chemical reactions with other small molecules. And these would include your antacids, your antiseptics, your saline laxatives, and your chelating agents. Interpatient variability in drug doses. This is the dose required to produce a therapeutic response that can vary substantially among patients. It is the measurement of interpatient variability, and you may hear the term ED50, which is the effective dose, 50%, and that's the dose that is. Clinical implications of interpatient variability. The initial dose of a drug is necessarily an approximation. Normally, when you start prescribing, you will be looking up, what are the initial doses or starter doses for many medications, and these have been done by the drug companies through their clinical trials, again, to see when 50% of the patients had a therapeutic response, so they make that the initial dose. But anything after that will have to be fine-tuned to the individual patient, what they are responding best to. So you may need to increase or decrease the dose. You may find that even that initial dose is too much for the patient, and that it's starting at a lower dose than is even recommended will be better for that patient, in particular patient. And you may find that some patients may need a higher dose, especially when I'm giving the medications for ADHD to the teenagers. Their metabolisms are so high that it's almost like jet fuel, so that they need many times will need higher doses than you would think, for someone young. But it's just that, again, that patient variability. One child may need one dose as opposed to another, and age can play a role in that. The next concept to be familiar with is therapeutic index. What is the therapeutic index? It is a measure of the drug's safety. It is the ratio of the drug's average lethal dose to 50% of the animals tested to its effective dose. So when you start to go to conferences, you'll hear the term number to treat and number to harm. And that's related to this therapeutic dosing. So the larger, higher the therapeutic index, the safer the drug is, which means it takes a much larger dose of the med to actually harm the patient. The smaller or lower the therapeutic index, the less safe the drug is. And those, think about a drug like lithium or some of your IV antibiotics where you have to do peaks and troughs, or with lithium you have a narrow therapeutic index, which means if you are not within that small range, the patient could become toxic and it could be lethal for the patient. Now we'll have some questions about the content from this slide presentation. So you're teaching your patient who has a gastric ulcer about cimetidine, which is one of the histamine H2 antagonists. And what would you include about the information with an antagonist? So the answer here would be C, that the antagonist presents receptor activation in the stomach. Okay, so it doesn't activate anything. Remember from the previous content, it doesn't make its own reactions at all. It doesn't change reactions, but it will prevent the reaction. Otherwise, there is no effect from it at all. What is true about a drug antagonist? And the answer here is B. An antagonist exerts effects by causing receptor activation. So that is it for the content for this slide presentation. Thank you.